Welcome to part 2 of this lecture on lumbar spine screening. In this portion of the lecture, I want to discuss further screening for lumbar spine, serious spinal pathologies, and also get into some of the clusters of signs and symptoms and potential red flags and risk factors that are pertinent to some of the more common pathologies that we may be screening for in the lumbar spine. So as we go through this, we want to think about our review of systems and our screening as really part of our comprehensive physical therapy examination. So it's nothing different than what we should be doing with our due diligence in treating all of our patients. And it does fit really nicely within the context of the information that we're trying to gather from our subjective and our objective examination. So as we start screening for serious spinal pathologies, I think it's nice to go back to putting this into the context also of what are our musculoskeletal diagnoses that we're expecting in the lumbar spine, so that we can start to differentiate or differentially diagnose. So we always want to be thinking about our MSK diagnoses and then what are the diagnoses that we're screening for. So take a couple seconds, try to make a list. You can pause the slideshow. What are your main lumbar spine diagnoses, and then what might be some serious pathologies that we're screening for. Okay, so our musculoskeletal diagnoses in lumbar spine can either be classified by a pathoanatomical diagnosis or a tissue of fault, and these are listed on the bottom of the left side of the slide. Or, as we're going to more in low back pain and lumbar spine, we can utilize a treatment-based classification. So I know you had this information in other classes, but just starting to think about what are some of the common findings with these mechanical low back pain diagnoses versus what we're trying to screen for or screen out, our serious spinal pathologies. And these are the main ones that I want to cover, I want to talk about in the remainder of this presentation. So Cauda equina syndrome, spinal fracture, spinal infection, cancer, and oftentimes, as we'll discuss, this is a metastatic or a secondary site of cancer would be in the spine, or an abdominal aortic aneurysm. And these top four are the main diagnoses highlighted from that position paper that we talked about, utilizing the clinical decision-making model, which we will come back to for another case study example as we go through these diagnoses. So how common are these serious spinal pathologies? Well, not as common as mechanical low back pain, not as common as non-specific low back pain. And it's going to vary based on the setting in which the patient is seen. So if it's a primary care setting for a medical doctor, a primary care physician, or in the case of physical therapy, if we're the first provider that that individual is seeing, the incidence of this is going to go down. So less than 5% of our patients presenting with back pain, with low back pain, are going to have some sort of serious spinal pathology. When you get into the emergency department, ED, emergency room, that incidence is going to go up, and estimates are anywhere from about 1% to 7%. One study that's noted here, it's a little bit higher than that, but overall we're thinking low risk of serious pathology doesn't mean that we need to screen. We definitely need to screen, but it's not as common. So we need to be able to pick up on these key indicators to try to pick these up, because these individuals are going to need care, and the quicker we get them care, the better, as we'll note on some of these pathologies. And then within these serious pathologies, fracture is going to be the most common, followed by cancer, followed by, depending on the research data you look to, either cauda equina or infection. So again, these are our main diagnoses that we want to screen for in the lumbar spine, and we'll kind of go through these in order. So with Cauda equina syndrome, what are the key signs and symptoms that you might be utilizing to screen for this? And then, not that you're necessarily going to be performing it or responsible for the medical management of this individual, but again, I think if we put this back into the context of medical system, what's the medical care that we are assuming that this patient is going to have, so that we can be informed and we have a sense for how these things are managed. Signs and symptoms for Cauda equina are primarily going to relate to part of the way that Cauda equina comes about. And so Cauda equina, if we remember, is the continuation of these nerve roots after the spinal cord ends. And off the distal end of the conus medullaris, the distal part of the spinal cord, we have the continuation of these nerve roots. So L2 through L5, and then the sacral and coccygeal nerve roots will continue in this horse's tail or cauda equina. The functions that these nerve roots serve are going to be motor functions to the lower extremities, sensory to the perineum and genital areas, and then bowel and bladder functions. And because of these nerve root functions or contributors, that's going to dictate, if those are impinged upon, some of the loss of function that we see. So primarily loss of motor function, saddle sign or perineal sensation that's reduced, and then altered bowel and bladder function. One of the most common ways that pressure is placed on these nerve roots and rootlets is by a disc prolapse. So not that you need to know that, but just thinking about some sort of either disc prolapse or a space-occupying lesion, a tumor pressing on these nerve roots, and their function is going to be reduced. As we see, one of the main things that we're going to be asking about in screening subjectively is asking about bowel and bladder function, and specifically urinary retention or the inability to urinate. Other bowel and bladder changes that we might think of as raising a higher suspicion of this pathology. So urinary retention, we just highlighted. Urinary incontinence has multiple potential causes, and so that is less problematic. However, if we pick up on that in the context of other signs and symptoms that might raise our suspicion, that might be important. And then with fecal changes, so fecal incontinence is more concerning because, again, it is more indicative of a serious pathology. Fecal retention or constipation has multiple potential causes. So medication causes, diet-related, fiber intake causes, age-related causes that might not indicate this serious pathology. And then with cauda equina, what is indicated? Well, referral for emergency MRI and surgical options. So we want to take away the impingement of those nerve roots. And it's really important that this is taken seriously, because the treatment for this is surgical decompression. The more quickly that this is performed, the less likely it is that the patient will have lasting deficits. And so it's really important that we identify these patients quickly so that they can get the management that they need. This particular slide and this reference is called a patient scorecard. But what I really think about this is a tool to help facilitate communication regarding cauda equina, common warning signs and symptoms. So as we discussed in our decision tool, one of the key things if we suspect this condition is to perform what we call watchful waiting. So as a physical therapist, you're monitoring a patient for symptom deterioration or increase in severity of these symptoms that might raise your suspicion of the serious pathology. But we're also doing what's called safety netting. So we're educating our patients on what are these things to look out for if they don't have them already, and if these things present themselves, what to do. And so this scorecard or this patient education handout is really, I think, quite useful to start to give patients a sense of autonomy in order to safety net them. If these things present themselves, what do you do? Well, any combination, it says right there, seek help immediately. So go to the ER. The other reason why I like this is because it helps facilitate communication around subjects that might tend to be vulnerable or harder to talk about. So bowel and bladder function, we want to make sure that they understand the serious nature of these certain nuances of loss or change in bowel or bladder function. So for example, not being able to urinate, losing sensation when you urinate, or sexual function, which is sometimes hard to talk about as well. So as a communication tool, I'd really encourage you to have this on hand or think about using this in the clinic. And again, to reinforce the idea that screening for cauda equina, how important it is, it's not a common syndrome, but we do want to try to, if we suspect it, get them an MRI imaging right away and further information to really make sure that they don't have this, because if they do, surgery is indicated. And most of the red flags that we're using, named above, are more specific than sensitive. If we remember our statistics, a high specificity test, we're going to use the acronym SPIN. So high specificity test, if they're positive, in other words, if they have urinary retention, if they have bilateral sciatica, if those things are present, then it's more likely to rule in. So we really do want to send them for further imaging. Okay, moving on to spinal fracture. So what are our key signs and symptoms for spinal fracture? And what might our medical management look like for these individuals? Some of our main signs and symptoms are female, increase in age, a major trauma, if somebody is point tender to palpation, and if that injury is distracting, in other words, if it's unable to be relieved, so not many easing factors, then we're going to suspect something more serious, such as potentially a fracture. And then some of the other risk factors are if somebody has low bone and mineral density, osteopenia, osteoporosis, history of spinal fracture, history of fracture, they might be more prone to this. Corticosteroids, as we know, corticosteroids are catabolic and so tend to deteriorate tissues. Thoracic pain also, spinal fracture is more common than thoracic. Medical management for these individuals would be diagnosis of it, so refer them for imaging to confirm. An X-ray usually is indicated primarily, however, an MRI may be utilized to try to differentiate the cause of the fracture, whether we think it is an osteoporotic cause versus malignancy can lead to compression fractures in the spine. So we do want to rule out malignancy or cancer if we suspect that. And then treatments, we can utilize conservative therapies, bracing, pain control, try to prevent future fractures. Surgery may be indicated, although not necessarily. So one of the things that we're screening for, again, if we have sudden onset of localized pain following a trauma, palpation pain at a bone, we do want to rule out fracture. As I mentioned earlier, possible underlying causes of the fracture could be osteoporotic or it could be due to some sort of malignancy. Spinal metastasis in the lumbar spine or thoracic spine, or the spine as a secondary site of cancer, which is spinal metastasis, is oftentimes common versus the spine being a primary site of cancer, and that's why that history of cancer is such an important thing to screen for. And just to note, some spinal compression fractures, actually the majority of them, may be asymptomatic. So just because somebody is asymptomatic or not experiencing pain doesn't mean we don't want to screen for it. So let's talk through this patient case. And this will kind of give us more practice with this decision tool framework. So patient here is a 58-year-old woman, has a long history of low back pain, history of breast cancer. She was diagnosed 5 years ago, and she's in PT because she has new onset of back pain, but she doesn't have any trauma. She hasn't been sick lately, her weight hasn't changed. She has some pain when she's first lying on her stomach, but she can kind of move around and get back to sleep. She doesn't have any radicular pain, and her pain is pretty mechanical. So you're able to reproduce her pain when she does a back bend. If she sits down and kind of rests, her pain goes away. So utilizing this decision framework, what's our level of concern with this individual? Can we pick out some things? Do we have any red flags? Do we have any risk factors? How severe are they? Is their pain reproducible? And then what's our decision-making process? Are we gonna, what's our clinical decision? Treat this individual for a low back pain, or do we want to refer? And then who would we refer to? So take a couple seconds and you can pause the show, pause the slideshow, come up with that and your rationale for each. All right, so for this individual, we really don't have any concerning features. She does have some history. She has a history of cancer, but it was 5 years ago. She has a long-standing history of low back pain. It seems to be mechanical. So within our physical therapy scope, we're going to treat. Obviously, we're going to monitor for the patient's changing symptoms, but we really don't suspect anything sinister with this patient case report. Our referral, if we don't have improvements in physical therapy, could be a primary care physician, could be an oncologist. And just like we said, this individual had a history of cancer 5 years ago, but she doesn't really present with other red flags. She has mechanical symptoms and history of low back pain, and episodic back pain is common. So we're really not suspecting anything sinister. Doesn't have night pain, doesn't have other concerning symptoms. And this, as we're going to get into, some of the ways that we're going to screen for spinal malignancy are this history of cancer. So she does have that. Increasing age is going to increase risk. She does have that. But she doesn't have any of these other things that might clue us in or make us think that she has a really high tendency or indication of cancer.